Hello, and thank you for your attention. I'm Patrick Matthews, the Delaware Basic Life Support Medical Director, and this is a special educational presentation for our EMS providers to describe some of the evolving trends in patient overdose and withdrawal from opiate use as the opiate epidemic continues. I'd like to introduce Dr. Greg Warner, one of my colleagues in the emergency department and a recent graduate of the EMS Fellowship Program. Greg has a special interest in addiction medicine and is now the EMS Special Projects Medical Director with the Delaware OEMS. He is a great resource and offers a wealth of knowledge on this topic. I will turn over the next series of slides to Dr. Warner to present his material.
Thank you, Dr. Matthews. As Dr. Matthews said, I'm Greg Warner. I'm an emergency physician, and I also work with the Delaware Office of EMS. So today we're going to be talking about a couple of things, including overdose and withdrawal trends locally and regionally. We'll also be talking about xylazine and medetomidine. So these are adulterants that have been mixed into the street opioid supply in recent years, medetomidine more recently, which we will discuss over the next few minutes. We'll also talk about medetomidine overdose and withdrawal. Let's jump into some of the local and regional data related to overdoses and withdrawal. On this slide, we see non-fatal overdoses that ended up in the emergency department in the year time frame between May 2024 and April 2025. Now, this is some of the most recent data that's available, and unfortunately, in this one-year time period, Delaware, as you can see here, was number 2 in the nation for non-fatal overdoses ending up in the emergency department. This slide includes information about ED visits for withdrawal in the Philadelphia area. You can see on the graph this gray vertical line suggesting when medetomidine was detected in the street drug supply. In the following quarters, third quarter of 2024 through the first quarter of 2025, you can see a very large increase in the number of ED visits for withdrawal in the Philadelphia area. Interestingly, in Delaware, especially Northern Delaware, we have seen a very similar, extremely large increase in the number of ED visits for withdrawal, suspected to be from medetomidine and opioids, fentanyl. So we'll talk a little bit about xylazine and medetomidine. Both of these medications are in the alpha-2 agonist family of medications, similar to the blood pressure medication clonidine, which you're likely familiar with. They are approved for veterinary use only. They are not for human use. Both xylazine and medetomidine are not for human use, but they are approved in the veterinary world. Unfortunately, both of these have been mixed into the street opioid supply in recent years. Xylazine, or tranq, was very commonly seen in the street opioid supply, but much less now over the past year as medetomidine has moved in as the predominant adulterant. Xylazine was associated with sedation and wounds. I'm sure many of you have seen or are still seeing the wounds associated with xylazine, and they're pretty unfortunate and impressive. Medetomidine, however, we have been seeing a lot more in the Philadelphia region, especially in northern Delaware over the past year, and it has spread from there since that time. So with medetomidine, we are seeing issues with overdose, issues with withdrawal. You can see here, this was a bulletin put out by the Overdose Response Center in Delaware in April of 2025. So it just gives some information similar to what I'm providing in this presentation. If you're interested in receiving updates from the Overdose Response Center, including bulletins like this or the monthly street drug report, just email orc@delaware.gov. So overview of medetomidine overdose or toxicity. In these cases, and I'm sure you've seen at least a couple of these cases where the patient is very sedated after an overdose. They're bradycardic, often with a heart rate in the 40 to 60 per minute range, sometimes a little lower, sometimes a little higher. Hypotensive, blood pressure is often in the 90s. Sometimes initially it's a little bit elevated, and then we'll go down slowly into the 90 systolic range. These patients with medetomidine overdoses, in addition to being bradycardic, they are often very sedated, so very difficult to awaken. You can give them naloxone, you can give them Narcan, and they'll start breathing, which is, of course, our goal is to get them breathing, keep them alive. But the hypotension persists, the bradycardia persists, and the sedation keeps on going. And usually they'll respond to pain. They'll kind of moan, may open their eyes a little bit, but they're still very sedated, and they don't wake up like we would typically expect after the naloxone. So, of course, you're going to give naloxone, but just note that the patient often will stay sedated and bradycardic even after the naloxone. That sedation and bradycardia often lasts for at least 4 to 6 hours in the emergency department. We watch the patients, and then they gradually start to wake up over the course of many, many hours. Medetomidine overdose and toxicity, BLS monitoring and treatment. So as I said before, you're going to give naloxone. As you know, that's no surprise. Patient is suffering from what appears to be an opioid overdose. You're going to give naloxone as per usual protocol. The goal with this really is to reverse the respiratory depression from fentanyl. Note that they will often remain sedated and somewhat bradycardic. Monitor the airway, monitor the breathing, check their blood pressure, frequent heart rate checks, keep them on a pulse ox, make sure they continue breathing and remain as stable as you can get them, and monitor their airway, of course. Just note that they typically won't wake up as we would expect with naloxone for just an opioid overdose, because this is an additional medication, a polysubstance overdose with the medetomidine and fentanyl. Both are mixed together, unfortunately, in the street drug supply. You're going to follow the suspected opiate overdose BLS protocol for naloxone, airway management, and observing the airway and calling ALS. Just note with naloxone, like I said, the patient will stay very sedated and sleepy and bradycardic, but they should start breathing. So that's your big thing, is just to keep an eye on their airway, keep an eye on their respirations, keep an eye on their pulse ox, keep their pulse ox above 92%, add supplemental oxygen if need be. And you can contact medical control if you have questions or concerns regarding all of this. Medetomidine withdrawal, however, is kind of the exact opposite. So this is where the patient comes in and they are very tachycardic and hypertensive, nausea, vomiting, tremor. We'll talk about some of those symptoms more in just a minute. Oftentimes this starts earlier than opioid withdrawal alone. So if the patient that you're seeing says, I used 6 to 12 hours ago and I wouldn't expect to be in withdrawal yet, but they are, this may be the case. Just note with medetomidine withdrawal, oftentimes patients are very hypertensive. 180 to 200 systolic or higher is not unusual. They're often very tachycardic in the 140, 170 range, also not unusual. They often have shaking and tremors initially, especially if they're not really talking to you much. You can confuse the shaking and the tremors for a seizure. But typically, if you try to stimulate them, give them a little painful stimulus, or just talk loudly to them, they will kind of open their eyes and make some contact, and they're in fact not having a seizure. It's just the shaking and the tremors from medetomidine withdrawal. If you're worried about a seizure, you'll just go about treating that and involving ALS as per your usual protocol. Just note that medetomidine withdrawal is severe. It's a severe withdrawal picture, and it's worse than opioid withdrawal alone. So BLS monitoring and treatment for medetomidine withdrawal, really, like I said before, you're going to monitor the airway, breathing, vital signs, pulse ox. Try to keep them in a calming environment as much as reasonably possible. If they can tolerate oral ondansetron or Zofran, you can give them a dose per your protocol. And note that if they have severe symptoms, they'll likely end up being admitted to the hospital. You can request ALS per your usual protocol for altered level of consciousness, respiratory distress, unconsciousness, or severe abnormal vital sign changes involve ALS as per protocol. So big takeaways for you to be aware of. Just note that medetomidine is strange. It's unusual. It's like something that we've not seen before in the emergency department. As I said before, it's being mixed into the street opioid supply along with fentanyl and other adulterants. In medetomidine overdose, you'll often see sedation and bradycardia, as well as some hypotension. In withdrawal, you'll see hypertension, tachycardia. The patient will be shaking with tremor, and they'll often stare at you and not say a whole heck of a lot. They'll just kind of stare at you while they're shaking, hypertensive and tachycardic. In overdose, like we said before, very important that you give naloxone. Now, the naloxone won't reverse the effects of medetomidine, but it will reverse the effects of the fentanyl and will keep the patient breathing. So give the naloxone until the patient's breathing improves, until their pulse ox improves. Give them supplemental oxygen as need be. Give that naloxone until the breathing improves, but just know that the patient will often remain sedated and sleepy and bradycardic even after naloxone. You're going to follow your BLS protocols for overdose, altered mental status, and general patient care. And I'll pass it back over to Dr. Matthews. Thank you, everyone.
Okay, special thank you to Dr. Warner for presenting this material. Hopefully you found this beneficial to hear some of the evolution in the opiate overdose and withdrawal presentations you may see as EMS providers. Obviously, this not being a live presentation, we can't really field any questions in this format. But if you do have any questions, please reach out to the Delaware OEMS or the Delaware State Fire Prevention Commission, and we will do our best to answer any questions you may have. That pretty much wraps up the presentation. The final slide is a references slide, which shows the sources that this material was pulled from. Otherwise, I thank you for your time and attention, and hopefully you found this helpful. Thank you.